Hello to everyone who is joining us. We're seeing the attendee ticker go up, skyrocketing. I will get started. Since we do have a captured audience, I'll just give a quick plug. Please make sure you're following OpenNotes on social media. This month, throughout August, October. What year is this? Throughout October, we're going to be answering questions to anyone who sends a question on social media using hashtag OpenNotes. And welcome to today's OpenNotes Grand Rounds webinar, Lessons from Canada and Sweden. My name is Liz Solmy, and I'm the Senior Strategist of Research Dissemination for OpenNotes. And behind the scenes today, making this webinar technically possible, are my colleagues Amanda Norris and Deb Wackenheim. In case this is your first time joining us, you should know OpenNotes, this proper noun with the snazzy logo, is based at the Beth Israel Deaconess Medical Center in Boston, Massachusetts, which is a major Harvard Medical School teaching hospital. As researchers, we've been studying the effects of shared clinical notes on patients, care partners, and clinicians for more than 10 years. OpenNotes works with collaborators around the country and overseas to foster and evaluate the spread and implementation of shared clinical notes. We call these OpenNotes. We are funded entirely by federal and philanthropic grants and gifts. We do not develop software or technology. We're really excited to bring you this webinar today. The concept of OpenNotes is not unique to the United States. In fact, when it comes to transparency between clinicians and patients, Canada and Sweden are among the leading innovators in the OpenNotes movement. To introduce today's presenters, I will now hand things over to Dr. Kate DeRoche, an associate professor at Harvard Medical School and the director of OpenNotes Research. Kate, take it away.
Thanks, Liz. I am delighted to be here with you today to introduce our two fantastic speakers. First, we will hear from Selina Brudnicki. She is the program lead of digital patient experience at University Health Network. And her healthcare and digital innovation experience really position her as one of Canada's leading authorities on patients' real-time access to their health information and data. And she also has tremendous expertise in co-designing interventions and collaborating with patients. We will also hear today from Maria Hagglund. She is an associate professor in health informatics at the Department of Women and Children's Health at Uppsala University in Sweden. We've also had the pleasure of having Maria here with us at OpenNotes for a good portion of this year as the Keane OpenNotes Scholar and a visiting lecturer at Harvard Med School. Her research is focused on user-centered systems that support collaboration and patient empowerment. In Sweden, she's explored the impact of patients' access to their electronic health records, including notes, through the National Swedish Patient Portal.
Thank you both for the presentation. It's a pleasure to be here, even though I'm in Uppsala now. As anyone who knows me knows that I love to talk about OpenNotes, and I love to talk about the development in Sweden. So thank you very much for inviting me. I thought I'd give a bit of a sort of development over time. So I entitled my presentation Past, Present, Future. So for those of you who are not maybe super familiar with the Swedish context, I just give a short introduction. So Sweden, well, I guess we've been sort of in the news for various reasons regarding our COVID-19 strategy, but let's not focus on that. We're a reasonably small country in the northern part of Europe. We have a population of about 10 million people, and healthcare in Sweden is tax funded, and it's provided by 20 or 21, depending on how you count, different regions. So each region will provide the healthcare in that part of Sweden, and they're very autonomous and can make their own decisions about, everything when it comes to their healthcare. There's also a growing number of private care providers, but they're all tax funded. Electronic health records have been used for quite some time and are implemented throughout healthcare in Sweden, both in primary care and in hospitals. And usually within a region, there will be one EHR system that is used both in primary care and at the hospitals. But since we have these autonomous regions, they all make their own decisions about what EHR system to use. So we have many of them. In general, we have a high internet access and usage it's almost 100% of the population will have access to internet. And I think in 2019, actually more than half of the people over 76 years reported using the internet on a regular basis. We also have a unique Swedish identifying number, which makes it easy to keep sort of track of everyone's data. And we use electronic IDs for most of our communication with, for doing tax returns and for parental leave, and also for accessing our health data, which we do through a national patient portal. So how did notes sharing develop in Sweden? Well, it actually started already in the 90s. There was a small pilot project in Uppsala, where I happen to live, where there was a general practitioner who, in his primary care center, he started a pilot together with the region, and about 500 patients were given access to their notes, and it was a big success. So the region decided that, well, we'll try this on a broader scale, but were then shut down in 2002 by the Data Inspection Board in Sweden, because the project was deemed not to follow the Swedish legislation at the time. Because in order to have direct access to the medical record, you had to be employed by a healthcare provider, and patients were not. But this caused a bit of a discussion in society. So it took a couple of years, but in 2008, we had a new Patient Data Act, which allowed patients direct online access to their notes. And as part of so Uppsala sort of started over again, and as part of a European project, a new version of giving patients access to their medical records was implemented. And in 2012, all the patients in Uppsala region gained access to their medical records in a local solution. And I know that it was in November 2012 because I was on vacation in Thailand, and I tweeted about it because I was so excited I had to go up to my hotel room and log in and see that I could actually use my record or access my notes and my medical record. So when it started in Uppsala in 2012, it was a very local solution. It was a direct sort of connection from the patient portal to the local EHR system used in Uppsala. But in parallel, there were other projects, and one of them was the development of a national infrastructure, a national health information exchange platform. And in 2014, the local Uppsala portal that gave patients access to their notes was moved to this national health information exchange platform. And based on the experiences from Uppsala, there was a national regulatory framework put in place, a first version. And it gave quite a lot of room for the healthcare providers to choose what data to share and when to share them. Then, since we were now on the national platform, other regions also started to connect. So in 2015, there were 6 more regions who connected and started to share notes. And there was also the opportunity, at least in Uppsala, for patients to comment on their own notes in the record, a very hidden and rudimentary function, I might add. There was some debate, because since each region had to, or were given the options to, pick and choose which information to make available, the view for patients became quite fragmented. So depending on which region you had received healthcare in, you might see some information but not others. So in 2016, there was a second version of the national regulatory framework, which states that all patients should have immediate online access to all documentation in tax-funded healthcare, including dental care. And there are very few exceptions where you can hide or delay information. For example, if there's a suspicion of abuse in the family, or maybe the police is involved in some investigation, or if there is serious concerns that the patient might come to harm. But this framework, it's now been in place for 4 years. It still hasn't quite sort of, I wouldn't say that across Sweden everyone has immediate access to all information. We're not quite there yet. But in 2018, at least the last of the 21 regions connected and started sharing notes. So since 2018, all of the 21 regions in Sweden do share notes with their patients. And I mentioned already that we do have this national patient platform or patient portal, and it's called 1177. And it might sound a bit cryptical, but it's actually because 1177 was the telephone number you use as a you can call that telephone number as a patient and get advice from a nurse about whether you need to seek immediate health care, or you can maybe wait at home for a bit longer. So 1177 was a very well-known brand for the Swedish population. And the National Patient Portal, you don't actually have to log in. It has lots of information for anyone to access about treatments or healthcare, where you can seek healthcare. And it has a lot of visits. In June 2020, the site had over 14 million visits, which is quite a lot for a population of 10 million people. And as you can see, it sort of spiked in, I think it's in March 2020 when the pandemic really hit. So it's been a very useful source for information for the Swedish population during the pandemic as well. And when you're on the National Patient Portal, you can use your electronic bank ID and log in, and then have access to personalized e-services. There are about 7.2 million accounts here, so you can calculate yourself out of 10 million how many. That's quite a big portion of the population who has at some point logged in and used these services. You can book appointments, you can send secure messages, etc. And in June 2020, 1.7 million individuals logged in at some point, and there were in total 7.1 million logins during June 2020. So it's used a lot. And of course, the most important e-service for us is where you can access your medical records. And then it looks something like this. It's in Swedish, of course, but you get the gist. You have access to your notes, your prescriptions, lab results, diagnosis, etc., referrals. And you can also access your children's record if you're their guardian. And you get your notes in sort of a timeline like this. You can choose if you want to see it in a different format as well. It works on mobile phones or mobile devices as well. And it doesn't really matter whether so I now live in Uppsala, so most of my healthcare is here. But if I go to a different region on vacation and I need to seek healthcare, or if I decide to move, the notes and the information from that healthcare provider will just show up in the timeline as any other, and you can see where it's from. So for me as a patient, it looks like it's just one big medical record. But of course, this is only possible because we have this national infrastructure, which looks something like this. I'm not going to go into the details, but it's what happens is you have all of the different EHR systems and other data sources in the bottom of the picture, and then there's a complex platform with application programming interfaces, which standardizes the formats that we need to have the information delivered in. And then at the top, there's applications for different user groups, where citizens are, of course, one of the most important ones. So how many people then actually log in and see their record or access their record? Well, we've had so far a little bit over 4 million unique users. So it's not everyone that uses the login services on the national platform that actually continues to access their record. But quite a lot still do. And as you can see, the curve is going sort of steadily upwards. And this is just a snapshot of September 2020. You can see how the adoption has happened over time, starting very slowly in 2012. And then as more and more regions connected, it has increased. In September, there were almost 1 million people who logged in, and there were 4.2 logins. So each of these 1 million people logged in several times. And that's usually because you have an ongoing health issue and you want to access information. And there's been a steady, the number of new users has been around 80,000, but now since the pandemic, it has increased a bit. So we're now up to over 100 new users per month, 100,000 new users per month. So it's the adoption is really, the pandemic is affecting the adoption. So what's next for note sharing in Sweden? Well, it's been I haven't really talked about the reactions to this. I've only talked about the numbers. It was a very controversial e-service when it was first launched in 2012. There were a lot of complaints from healthcare professionals, especially. Patients have sort of consistently loved it from the beginning. Even though it takes a bit of, as you can see, adoption hasn't been sort of, not everyone found the service from the beginning, but it's increasing over time. And it's one of the, I would say, more popular of the e-services on the Swedish platform. One thing that we haven't done much of yet is patient-generated data and how to integrate that into the electronic health records. I mentioned that patients can write notes in the record, but this is a very underutilized and sort of hidden function in the system. There's also some work more and more looking into different forms of self-tracking and monitoring and exploring ways how we can integrate this data into the data that healthcare already has about patients. There are some tricky areas, for example, access to mental health records. At the moment, from the beginning, a lot of the regions would hide this information. Now we're at a point where I think about half of the Swedish regions give patients access to their mental health records as well. But there are special challenges there. Proxy access is another area that we're still struggling with. There was a function in the record where you could share your record with someone, or you could share parts of it, or at a certain time period. But this was also shut down by the data inspection for not complying with legislation. They did not feel it was safe enough. Adolescent access is one of the other tricky areas where at the moment, as a parent, I have access to my children's records until they turn 13. They themselves gain access at 16, so there's a 3-year gap where I don't have access and they don't have access. And we're not entirely sure how to fix that yet. And then, of course, there's a lot of still, even though we do have a high percentage of internet users, there are still quite a lot of people who don't access the internet and who probably won't either. And that's a question how to reach them. And finally, the national platform, as I mentioned, it's now been in place for quite a few years and it's in need of an update. So the infrastructure is now in a process of being updated, and there's also a lot of new digital services such as telemedicine and triage services that are being integrated into the platform that will likely also affect the way we use OpenNotes in Sweden. And I think that was all from me. Thank you.
Thank you so much, Maria. That was awesome. I already have questions, but I don't want to cheat the line and ask my questions before everybody else. So we're gonna, and while you're presenting, I was getting text messages from folks who are watching this presentation who are really excited about what you're saying was going on in Sweden, really parallels what we're seeing here in the US. So everyone has stuff to learn today. I'm now going to pass it on to our next presenter, Selina Brudnicki at the University Health Network in Toronto, Canada. Take it away, Selina.
All right. Well, thank you very much, Liz. And thank you for the invitation to discuss OpenNotes Lessons from Canada. You know, I'll never forget the time when I presented to a committee of medical leads at Princess Margaret Cancer Centre here in Toronto. My colleagues and I had been collaborating with over 80 patients, caregivers, leaders, and frontline staff from across multiple specialty areas to plan, design, and build a new enterprise patient portal called myUHN. And at the time, we were looking for a few early adopter areas to roll out and evaluate this portal, which would enable patients with real-time access to their appointment schedules, as well as results, reports, and clinic notes made available to patients at the same time it became available to their care team. There was silence in the room. And what seemed to be the longest 8 seconds of my life, some physicians actually stepped forward. Days later, a colleague had said to me, Selina, one of your physician champions felt pressured to volunteer, and he expressed concerns to the committee. So to put it mildly, he does not want to participate. I think you should talk to him. So today you're going to hear about some strategies, successes, challenges, and some lessons learned related to patient real-time access to their medical record, including OpenNotes. Now, I'm going to take a few steps back and provide you with context about healthcare in Canada. Our healthcare is publicly funded. We have universal coverage for medically necessary healthcare services that are provided on the basis of need rather than the ability to pay. We have provincial and territorial governments that have most of the responsibility for delivering health and other social services. Our federal government is responsible for some delivery of services for certain groups of people. But similar to Sweden, healthcare is generally financed through taxes, but also revenues. Now, in some provinces, such as Alberta, there are coordinated provincial efforts to provide a single point of access to medical records to our care teams through a health information system, and also to citizens through one patient portal. But in other provinces, such as Ontario, we have a best of breed environment. It is possible that there may be a central provincial repository held by our provincial government that pulls the data together from many organizations and makes it available to the patient's care team, maybe even to patients themselves, but that data is in no way complete. 85% of our family practice physicians in Canada, 79% of our specialist physicians report using an electronic medical record, but only 22% of Canadians can actually access parts of their records electronically through different ways. So sadly, in Canada, we only have 4 healthcare organizations that are recognized by OpenNotes for sharing their notes with patients. These organizations are focused in the Ontario and Greater Toronto Area region. And you can see here that one of these organizations is University Health Network, or UHN. UHN is known as Canada's largest hospital-based research program. It includes Toronto General, Toronto Western Hospitals, Princess Margaret Cancer Centre, and Toronto Rehabilitation Institute. The organization specializes in cardiology, transplant, oncology, infectious diseases, and surgical innovations, among other specialty areas. We have about 1,200 inpatient beds. We see more than 1 million ambulatory visits per year. Now, you can actually see from this slide that UHN actually has a 16-year journey of patient portal experience. We've had implementations at research, pilot, and enterprise levels across all our patient populations. And historically, we have always released real-time results and reports for certain patient populations. But it wasn't until 2015 to 17 that our electronic results, reports, and notes, including our mental health notes, became available for patient access as part of our enterprise patient portal, myUHN. So in the early days of our project, we very quickly discovered that there were three main areas where patients and our clinicians were not on the same page. Clinicians were concerned about patient immediate access to their results and reports, especially the pathology results, and they felt patients should receive their information and potentially any bad news in person, so they recommended delays for some sensitive results and reports. They had concerns about patient access to their clinic notes, and especially the mental health notes. And there were concerns about what this would do to the patient-provider relationship, their workload, and also their call volumes. Now, on the other hand, what patients told us was that they wanted timely access to their online medical records because they were at the center of care and the one constant that was managing multiple provider relationships. So having their information would actually decrease their anxiety and mental stress of waiting. They would be able to process information, including any bad news, emotionally at home. And then having that access would actually help them better understand their condition, prepare for appointments, and actually take responsibility regarding their own health. So what many people don't realize is that in 1992, there was a well-known court case where the Canadian Supreme Court actually ruled that patients have the right to access their record, including all the information in the file, which the physician considered in administering advice or treatment. And in some provinces, such as Ontario, there is also additional privacy legislation in place that states, with limited exceptions, individuals do have the legal right to access and request correction of their own personal health information. So it was actually our providers that recognized that results, reports, as well as the notes are an essential part of decision-making, and it followed that this information should be made available to the patient. So at UHN, we have a primary value: the needs of patients come first. And we did ask patients to prioritize their needs. So what they told us was that they wanted access to their appointment schedules and reminders. They wanted real-time access to results, reports, clinic notes. They wanted to navigate to trusted education sources, and they also wanted the ability to share their health records with others. So in 2015, this portal became available to patients in early adopter areas, and in 2017, we proceeded with an enterprise rollout. Now, patients also told us that it was important for them to access records from other organizations outside of UHN as part of continuity of care. So over the past few years, we also worked closely with our Ontario Health Government and so many individuals behind the scenes to review legal agreements, privacy, security standards, and we completed connections to the provincial data using interoperable standards. So as of August of this year, very recently, all patients using myUHN now have access to their provincial or Ontario lab results, including their COVID-19 results from over 150 healthcare organizations, from community and public health labs, as soon as they become available in this provincial repository. What you'll see on the screen is that our one-year project evaluation actually showed that 94% of patients reported improved patient experience. They felt better prepared for appointments, they had improved management of care, improved communication with their care team, and they were better able to make decisions because of this transparency. Now below that graph, or this graph, you'll see that staff perceptions were a little bit lower. However, over the years, we actually have been seeing a significant change and increase in terms of communication and the perceptions about patients making decisions. Also interesting to note is that 10% of patients found out of date or incorrect information in their record. There was no significant impact on the Princess Margaret triage call volumes for a majority of the sites, but we did receive anecdotal feedback that some of the calls to the physician offices had increased. However, we did not have any pre or post data available. So year after year, when we ask patients, we continue to see that more than 9 out of 10 patients prefer real-time access. And what you see on your screen here, I think this quote summarizes the sentiments very well. The patient says, "I prefer to have my results right away, even if they may be worrisome, because I have a right to that information. I find it more worrisome to not have the information. And when I do feel worried about my ability to interpret the results, or when I don't know when, or when I don't know, and I don't want to know until I consult my healthcare team, I simply don't look." Today, we actually have over 150,000 registered users. And before the pandemic, our registration rates were very steady. But post-pandemic, we have seen an uptick in the portal registration because patients and staff are being tested for COVID-19. I think this has highlighted what we really knew all along, that there is an urgency for patients to access their record right away. Their health information is critical for decision-making and continuity of care. And we also know how important it is to have a dedicated support team with patient engagement experience to provide ongoing change management, education, and support for our patients and our staff. So here are a few tips to consider about real-time release. At UHN, patients are accessing their information as it becomes final and available in the hospital's main electronic record. Information blocking of patients to their own data is by exception only. So similar to Sweden, it is based on bioethical reasons or legal reasons. And for us, these reasons must be documented in the health information system, which is audited on a monthly basis. Now, to date, no provider has blocked a patient from access. So here's some additional advice by some of our medical and other colleagues. First, explain to the patient what and why specific tests are being ordered, and prepare the patient for possible outcomes. Provide information about what to expect next. Second, accuracy of documentation is key. Double check the accuracy of your residents, fellows, medical students who dictate on the physician's behalf, and this would help to reduce the need to correct notes due to inaccuracy of dictation. And third, be sensitive to the patient, but do not omit or avoid important information that is relevant to their care. And finally, if you think a patient may become anxious, advise them to look at the results during or after their visit so you can remember and review results together, or so that they can remember what was said at the appointment. Now, remember the physician who felt pressured to volunteer? He actually became one of our early adopter physicians, and he actually became a great champion. a couple of months after go live, he said to me, Selina, you've convinced me. Feedback on the myUHN patient portal has been excellent. There is no going back. And since then, I'm happy to say that we continue to see some remarkable clinical teams who take the lead in partnering and having meaningful engagement with their patients. But admittedly, for a minority, some are still adjusting to the change. I'm just going to leave you with some final thoughts. Now that you have heard some strategies, successes, challenges, and lessons learned, I hope you can see that building a new paradigm of trust through patient immediate access to all of their medical records will empower patients like never before and improve that patient-provider relationship. There is no going back. Thank you.
Wow, thank you so much, Selina. Just to quickly comment, there's so much you said there at the end that was super relevant to what we're seeing here in the United States with some new public policies and federal rules going into effect around interoperability and information blocking of patient access to information. I want to hand things over. We're going to now move into the Q&A part of this webinar. Remember, you can turn to the questions box, should be on the right side of your screen here, and go to webinar, and you can start entering your questions. We've already received a few over the last 40 minutes, and moderating our Q&A is Deb Wachenheim, who's the Assistant Director of Research Dissemination for OpenNotes. Deb, what are we seeing in the questions box?
Okay, so a couple questions first for Maria. Are the EHR systems used in primary and secondary care in each region common, even if different between the regions? So within a region, are they the same?
Yes, in most regions they are.
Okay. So then you did, this question came in pretty early in your presentation, and you did touch on this towards the end, but if you want to say anything more, this person wanted to know more about what isn't shared, such as mental health and pediatrics. If those areas are routinely shared, have there been any adverse effects?
So there are, there is sharing of mental health records. There is also sharing of pediatrics records. There hasn't been any sort of major issues. Some anecdotal that we hear of, but not. There's no. To be honest, there isn't really much research into or data on adverse events, but there hasn't been a huge. It's been similar sort of non-events as when OpenNotes is introduced in other areas. It doesn't. There's a lot of worry beforehand, but then things sort of run quite smoothly. There has been some reports of, especially in mental health care, that clinicians feel that they can't document everything, that they keep things out of the record, which would of course be a big problem, a big issue. But there hasn't yet been, this has been sort of subjectively reported and not confirmed. So,
and Selina, I don't know if you'd want to add more on that topic as well, mental health and adolescent notes, and if you've seen any adverse effects.
Yeah, I think, you know, there's probably always going to be case-by-case basis. We don't see a lot of adolescents in our environment, and we don't have pediatrics. But I do know that from what I have seen, some of the, or many of the clinical teams really do try to focus, and they try to make improvements within their own environment. So, you know, they do look within their own program areas at how to improve, how to communicate with the patients, and have internal discussions about how to improve their documentation as well.
And then the next question was directed to Maria, but I think it'll be interesting to hear both of you respond. Sweden approached the COVID-19 pandemic quite differently than many other European countries. How has this approach impacted, if at all, the use and dividends of OpenNotes? So Maria, if you want to talk about Sweden, and then Selina, if there's anything relating to COVID and OpenNotes that you want to talk about. Go ahead, Maria.
That's a bit of a difficult question to answer. I'm not sure if it has affected how we use OpenNotes or how we access our records. Similarly to what Selina described, of course, we see there has been a lot of testing of COVID and antibodies, and we do access those results through the patient portal. So it definitely, there has been an uptake in the adoption has increased, similarly to what Selina presented from Canada. Of course, since we've had, we haven't had as strict a lockdown as other countries. Now, I have to admit that I was visiting OpenNotes in Boston during the worst of the pandemic, so I wasn't actually living in Sweden at that time. But of course, we've instead had quite strict rules about isolating at the mildest symptoms of a cold, which means that people have been a lot more on sick leave and working from home. So, but whether or not that has impacted how we use OpenNotes, I don't think so.
And then it's Selina. I'll also add, I don't have actual data at this time to see what is happening to the notes themselves, but of course, with the pandemic, our patients and staff are being tested, so the access to the COVID-19 results are important, and there's definite urgency in seeing that. I think what we also have been hearing is that because of the virtual care environment, which is very high now, patients are not coming into the hospital. They may be getting tests outside. They may be getting care at other organizations as well. So that's why having that access to that information is so important, right? And that's about that patient empowerment and making sure that access is available.
Maria, there was a question about what type of information patients input into their medical record?
Not much at the moment. I mentioned that there's something that we call the patient's note, and this is a very rudimentary function where on a note in the record, you can activate a function so that you can write a comment on this note. You can't write your own notes independently of what is in the record, but you can comment if you sort of want to clarify something, or you feel that there was a bit of a misunderstanding, but it's maybe not enough to report, or you just want to make a memory, a note for yourself. So I have, for example, used it for myself in between visits, just to note down things that I want to remember to bring up at the next visit. But it's a very short free text box. It's not much data going in there at all. And it's you have to activate it every time. It's been designed not to be used. So I'd almost prefer not to talk about it because it's a bit embarrassing. But hopefully we will be able to redesign this and make it more useful to both patients and clinicians.
And here's an interesting question for both of you. Any evidence that sharing medical notes has increased patients' health literacy?
We don't actually have evidence for that. Not that I'm aware of. We have sort of asked questions whether patients find the record difficult to understand. And most people, at least who responded to our survey, said that they did not find it very difficult to understand, although they also said that there was a lot of medical terminology. But I think that many people sort of understands their notes a little bit based on the context, and you know what you were seeking care for, and when there's a few of those difficult words, you look them up. So there hasn't been, but on the other hand, we haven't necessarily heard from those patients who might have the lowest health literacy, and they are likely the ones who do not actually access their records as well. So but this is a really interesting topic that would be very interesting to explore further.
Yeah, I would agree with Maria. I don't think there's a lot of literature, and definitely for UHN, we have not done some, in-depth studies about health literacy. What I do know, and this is, more anecdotal, is that I have heard from patients that initially, when they look at their notes, especially, they do have challenges on what it means. Within our portal, we do try to provide a glossary of terms. We have an acronym library as well, so patients can look it up. But I think over time, and especially because our clinicians know that patients are looking at those notes, we're seeing that there's a genuine attempt to improve, that documentation. And I remember from one patient, he had said to me, I may not have understood it at the beginning, but now, even though I may not know every single word, I generally understand what they're saying in my notes. So I think this is an evolution, this is an iteration. We're not going to get it perfect the first time, but it's a way for both patients and our clinicians, our care teams, to learn together and to actually, sort of see what the benefits would be and how to improve as well.
So another question for both of you. One of the top concerns we have been getting is about immediate open results. How best do we handle the situation where patients are likely to receive cancer biopsy results before their provider sees them in the EHR?
Maybe I can answer that first. I did refer to some pieces of advice during the presentation that you could refer to there. We also found it important. Originally, when we launched with our portal, what we found was that our clinicians are busy. They're all day in the clinic, they're doing surgeries, etc. So a lot of times the patients do see their results first because they get notifications as soon as it's available. And what we had to do during the course of the implementation was that we actually sent alerts to the providers right away if any results looked abnormal, so that the providers had an opportunity to look at the results. I think in general, what we heard from patients was that, they don't expect the provider to kind of look and have a plan right away, but they do want to have some, kind of sense of relief that somebody does know about it, and that there will be plans to contact them and to follow up for a next visit. Maria, I don't know if you have any other insights from Sweden.
No, but the same concerns, of course, have been raised in Sweden as well. And the regions have taken slightly different approaches to, whether you should have a sort of 2-week embargo or whether you should have immediate access. Most are now moving towards immediate access, as is also recommended in the regulatory framework. We have done studies with, for example, there's been a very interesting interview study with cancer patients who, 15 patients who chose to read their record and 15 patients who chose not to read their record. And, their rationale for doing either or. And I think for many, it comes down to a very personal choice. And many of the cancer patients who chose to read their record, even though they might be expecting bad results, or they explain this as, the wait is one of the worst things when you're expecting. You know that it could be good news, it could be bad news. And many of them felt that they preferred to receive the bad news at home maybe alone, maybe being able to break down and cry, wrap your head around your thoughts, prepare for the meeting with the clinician, have your questions ready, rather than sort of being in a very, stressful place and just going into shock in an appointment with a person you may or may not know very well. So it's also, I think that we sometimes we take for granted that some ways are better to receive results. That may not always be what patients prefer. Of course, those results, when you are completely sort of blindsided by them, you were in for a routine appointment and then all of a sudden it turns out that there was something very serious going on. Those are more difficult. But I also think that, and this is my sort of personal reflection, is that sometimes we idealize the way that bad news is delivered today or without OpenNotes. And we sort of envision this ideal image of how patients receive bad news today. Whereas the truth is that many of us have sort of, that missed call, you realize something is wrong. You have to come, you're called to an appointment, you have to come to the hospital, perhaps bring a family member, and then it's bad news beforehand, but you don't know how bad or, So I think sometimes we idealize the way that that news is delivered outside of the record. But of course there are, it's not a, bad news is never what you want to get, regardless of if you read them in your record or if your physician tells you. So.
Thank you. A question that maybe Kate DeRoche would want to take first, and then if Maria and Selina have any other thoughts to add. Have you broken down OpenNotes use by racial / ethnicity populations?
I can, excuse me, this is Kate, I can try to answer that. So we have survey data that and we did ask the race and ethnicity of the respondents, but it's not really, I would hesitate to say that that's reflective of the whole population, because it's only people who were getting their care at these individual institutions. So I can say that what we've seen over the last few years is a growth in safety net organizations opening notes to patients. So for example, LA County Department of Health shares notes now, and OHN, which is the EHR the EHR provider for federally qualified health centers, they also have all of their clinics are sharing notes. So we know that it's growing. It's a little bit hard to walk that back, though, to a proportion of the population, because we know still that people who identify as a racial or ethnic minority are both less likely to be offered access to a portal, and when they are offered access, are less likely to use it. So I would say that there's still a little bit of a kind of a black box happening there. What we do know from our surveys, though, is that patients who identify as coming from a sort of traditionally underserved population, racial or ethnic minorities, people with limited English proficiency, they do report benefits from reading their notes at a higher, they're more likely to report benefits from reading their notes than patients who are than white patients or patients with higher levels of formal education. So it is beneficial for them, but we can't really say much about the proportion of each racial or ethnic group that's reading their notes.
Selina or Maria, do you have anything to add to that?
I guess within the Toronto region, we do have a very diverse, demographic. There are many different cultural differences among the different regions. I think for our portal, we have never studied sort of the breakdown of who is actually accessing and what those demographics are. I suspect that health equity, access to services is going to be even more important, and we are seeing that now, even with the pandemic, right? So kudos to OpenNotes for doing all of this wonderful research. And I hope that, in the future, other organizations will follow suit as well.
So I think we have time for one more quick question. Maybe we have 1 minute left. On the aspect of understanding case notes, is there any evidence that the format and clarity of the notes has improved? In the UK, case notes have a really high and wrong use of abbreviations. To make case notes patient-friendly, clinicians would need to use acronyms less. So if either of you want to talk about, has there been any work to improve notes to make them more patient-friendly?
Yeah, there hasn't really been that work, I think, in Sweden, although it is encouraged, and there are, some work probably trying to address that. We do have in the patient data law since the 70s, it states that the record should be written in a way so that the patient could understand it. But we also have a lot of abbreviations and things that may be less easy for patients to understand in our record, so it's not really been followed.
Yeah, and I think if there are any vendor technology or technology vendors in the audience, this is an opportunity, I think, and we are seeing that in many health information systems that there's more standardization in the way our providers are documenting the notes, and ideally in the future we should be able to see parts of it where it is sort of a translation in a sense to communicate better to our patients, to provide the summaries as well, in addition to that detailed information. So there's so much improvement that could be made. And again, I think in the future we'll also start to see the opportunity where patients can start to contribute as well and interact with their notes, with their data, to self-report, to upload information. So there's so much opportunity in the future for improvements.
And on that note, pun slightly intended, we are at time and we're going to close things down. Thank you so much to today's presenters, Selina Brudnicki and Maria Hagglund. You guys were fantastic, and I think so many folks are going to leave today having learned a lot. We've had many attendees on today's call and a ton of questions. We are capturing everything. We will be posting this recording up on our YouTube channel very soon. And since you were here today, you'll definitely receive an email with a link to that recording, which you can share with any of your colleagues anywhere you want to put it. Thank you everyone so much. If you have any questions or want to know what's going on with OpenNotes right now, definitely visit opennotes.org, sign up for our email list, which I think you're actually now on. Since you're here today, you'll get a couple of emails from us. Thank you so much for being here. Again, I'm Liz Salmi. On behalf of myself, Director Kate DeRoche, and the rest of the team, have a great day.